Thank you very much. Hello, everyone. This is Dr. Tony, and I'm really very pleased to have an opportunity to share with you through my conversation with Dr. Roberto Luis Fernandez on a topic that really everyone is struggling with. And so, just to give you a little bit of the background of Dr. Lewis, he's a professor of clinical psychiatry at Columbia, the College of Physicians and Surgeons, and he's the director of the New York State Center for Excellence for Cultural Competence and the Hispanic Treatment Program. He's also co-director of the Anxiety Disorders Clinic at the New York State Psychiatric Institute. He's also a lecturer on global health and social medicine at Harvard University. So Dr. Lewis' research focuses on developing clinical interventions and novel service delivery approaches to help overcome disparities in the care of underserved cultural groups. His work centers on improving treatment engagement and retention in mental health and physical health care by persons with anxiety, depression, schizophrenia, and other serious mental health problems. He also studies the way culture affects individuals' experience of mental disorders and their help-seeking expectations, including how to explore the cultural variation during a psychiatric evaluation. Now, Dr. Lewis really led the development of the DSM-5 cultural formulation interview that some of you may be aware of. And it's a standardized method for cultural assessment for use in mental health practice, and was the principal investigator of its international field trials, really around the world, in Canada and India, Kenya, the Netherlands, Peru, and the United States. So it really is an honor to have Dr. Roberto Luis Fernandez with us today to help, for us to gain some insight into how we improve our practice to having a greater sensitivity and awareness around cultural factors, and then some really practical ways for individuals in your practice, all of you out there who are involved in care of others, to integrate some of those concepts into your work. So welcome, Dr. Lewis.
Thank you.
Very
Thank
much
you for
appreciated.
having me.
We were chatting a little bit before that you didn't start out in medicine, right? That you started in comparative, religion was an area of study. But somewhere along the line, you decided that the area of cultural factors in mental health care was going to be an important part of your life's work. Why is that? What led you to believe that that would be an area you really wanted to focus on?
Well, yes, I was earlier in my career interested in religion in particular as a field of study, and what attracted me to religion was the way people made sense of their life. So the changing ways in which people in different communities and over time had struggled with very similar questions about death and meaning of life and children and suffering and all these issues. And so I carried that idea over into something that I felt was applied to mental health struggles, which is the area of culture more generally. Religion being part of it, but culture more generally in the sense of how people make sense of experience and practice their lives and fit in a society in certain ways, understanding all that as part of the way that we try to understand what's going on with them and try to help them. So it was a very practical concern as well as a kind of intellectual concern.
Okay, that's great. People have had many of the folks out here who are listening, they've gone to cultural awareness and cultural sensitivity and those sorts of issues that folks struggle with. And sometimes it's not clear on what do we mean really by culture. What are we talking about, and why is that so important for us to be aware of in the work that we do?
That's a great question, and I hope I don't take the whole hour trying to answer it. But I think I will want to make a couple points. One point is that what we mean by culture, which is a very difficult word to define, and everybody has a different understanding, and there's a whole field called anthropology. All they do is debate about what culture is. Yeah, but the practical way, if you will, that we use the term in DSM-5 and in developing this evaluation approach, the cultural formulation interview, is as culture as the set of meaning-making processes and practices that people do, engage in, think, believe, act, in order to make sense of the experience. So in that sense, everybody has a culture, as opposed to the kind of American idea that culture is minority status in some way. So if it's sort of extreme version of that idea is that somehow there are people with culture and people without culture, kind of normal people and then different people.
Right.
And our approach is entirely based on the idea that everybody has a cultural understanding. Everybody is part in practice. Everybody is part of a number of communities, and they derive their sense of the world from their participation in those communities. Mm-hmm. So, we all make a meaning of our own, by ourselves. We all have our own sense of what meaning is in our lives, but we don't make that up out of nothing. We create meaning in our own individual existence because we've been exposed to multiple meanings throughout our life. Mm-hmm. So by virtue of being of a certain age, of a certain gender, a certain sexual orientation, religion, language, race, ethnicity, profession, any number of
a lot of identities there,
yes,
right?
yes,
a lot of identities there.
That's right. And we are the intersection of all these identities that we also then change ourselves. So it's a very fluid process. It changes from, when you're engaging in one setting or another setting. When you talk about your mental health type problems, you're not the same person, if you will, if you talk about them in church, than if you talk about them with your psychiatrist or with your, physical health doctor or with your boss. I mean, you would talk about them differently and think of them differently because they have different aspects, and you are participating in those communities in different ways. So what we do with the cultural formulation interview, or with the whole idea we have about culture and cultural evaluation, is to try to understand that complexity of background and experience and meaning making in order to help understand what the person thinks of the situation, how they look at it, what is it they expect, what is it they want us as providers to do, what is it they don't want us to do, what they tried before that was really counter to the way they think about it. Now, I just want to add one more point, which is the second point, if you will, which won't be as long as the first one. But the second point is that what I've said would be helpful, all this appreciation of culture in a person's life would be helpful for anybody, not just people who suffer from disparate care, unequal care. So if you're a very wealthy person with every privilege in life, it's still very useful for your providers to know how you think. So there's a person-centered element to it that transcends whether you have had equal access to care or not. At the same time, having said that, misunderstanding of people's, the things that led to the illness, the social determinants of health, the structure of society in which the person fits that has led them to experience certain problems, that has led to the mental health struggles, their own understandings and expectations of care and past experiences. All that is even more important for people who haven't received good care. So it's sort of like a corrective, if you will, that is good for everybody. So we use it, we advocate its use for everybody. But there are certain uses of it for disparity reduction that are particularly important.
So what was the problem in our current system, current practices, that you were hoping to address with creating this resource and tool, really for the field, right? And that's what a lot of the work was. Let's create some resource, some tool that others can use to address a prevailing problem. And how would you describe that prevailing problem?
Right. That's also a long answer, which I will try to not go on forever about.
I'll try to ask a lot simpler questions.
Just ask me 2 or 3 questions.
Okay.
And I'll just speak for the whole hour. No, I'm kidding. No, it's a great question. But the issue is that there are problems at many levels to answer. One problem that this is trying to address is the whole issue that there are communities, the whole disparities angle, that there are communities whose expression of illnesses doesn't quite conform to what some providers expect, or their explanations are off according to the providers, so that there's a lot of misdiagnosis that we're trying to help correct. So for example, there's an epidemic of misdiagnosis of psychosis among certain communities, particularly, famously, if you will, African American, especially men. They're just consistently, in study after study, here in the UK, all sorts of places, overdiagnosed as being schizophrenic when they're not. They may be having a bipolar illness with some psychotic features, but they're not schizophrenic. They don't have schizophrenia, or they may just be, concerned about they're the way they're being treated, and that's being taken as paranoia. I mean, there's so many ways in which there are misdiagnoses all over the place. One study that used a cultural formulation approach in Canada found that of the 70 people who were referred to this consultation service for cultural evaluation, half of them, meaning of the 70 people who received a diagnosis of psychosis when they were sent to the consultation service, half of them were re-diagnosed as not having psychosis.
Oh, that's huge.
Yeah, it's huge.
I mean, that's huge.
Yeah, most of them were immigrants from places where there had been wars and they had PTSD with some features that reminded people of psychosis, or they might attribute their illness to something that felt bizarre to the interviewer, like witchcraft or something like that, but which for them was just a way of speaking about their relations with their community or their family, but it wasn't that they thought.
Right. One of the, it's interesting you raised that issue is, and just this very quick story that, you kind of remind me of. I'm from Sicily.
Mm-hmm.
We were talking before, if you're Puerto Rico, I'm from Sicily. And if a family member was to say, grandma who died years ago visited me last night.
Right, exactly.
And told me that I better not do certain things because I'd get into trouble. We're not going to send her off with an ambulance to the quickest, in fact, some family members might say, listen, the next time she comes by, ask her where that ring was.
Right, exactly. Reminder, we're still.
Right. So it's kind of like that sort of like perspective. And I mean, it's much more, that's not a negative outcome, but the perception of unusual behavior or bizarre behavior, there's a cultural context to that.
Yes.
Which is what, and we can make a lot of mistakes.
Yes.
I think that's what, a very important point for everyone out there. Like, why is this so important that we look at this? Is that you can do harm.
Yeah.
Right? If you don't have a lens on, and as a core competency in many ways, to be able to engage someone, to understand their experience from their framework, right, that we can really cause some harm. I think that's what one of the possibilities it seems to me.
I agree completely. And to give another short example was a person that I saw in the emergency room once in psychiatry many years ago, because this one's an example a little bit of the structure in which the person worked and how that structure contributed to worsening her situation. This was a Latino woman somewhere in Central America who was working at a hospital cleaning as a cleaning person, and slipped and fell on the floor and hit the back of her head. And she became very concerned that maybe she had an injury that needed attention. And so she wanted to have an x-ray of the back of her head. But she was taken by the job to an emergency room where they said essentially, we've examined you, you don't need an x-ray. And she was very worried. So she kept insisting, no, I need an x-ray. I imagine there was all sorts of pressures at work, all sorts of reasons why this was even worse than it sounds in some ways in this account. And so when the person said that they insisted, no, you won't get an x-ray, your insurance doesn't cover it, this kind of thing. So she went outside to the waiting area and was crying that she hadn't gotten the care that she needed. And one of the people who work at the ER came out and said to her, stop crying, there's sick people here. And she just lost it. She had one of these episodes of loss of control called nervous attack, ataque de nervios. In the emergency room, she was put in 5-point restraints and sent to the emergency room where I was the doctor. And all it took at that moment was just asking her what had happened. She was at that point completely able to explain the whole situation, what her expectation was, why it wasn't met, what it was that she was afraid of, permanent damage, all sorts of things, that people had these accidents at work that hadn't been found, and so she was afraid. So all that, you just get that story, and she didn't need 5-point restraints. She didn't need anything. She didn't need an emergency room in psychiatry. She needed an x-ray.
Right.
So we did an x-ray, and she was perfectly fine.
Yeah. So that's sort of like the critical piece, that all good clinical care, that one of the first tasks that we have, and that's true for everyone who's on this, who's listening to this right now, in the work that you do with your clients, understanding their perspective is like job one, right?
That's
Before
right.
we share our perspective. But understanding the various identities individuals have and how their culture, religious, all the various things you had mentioned, shapes that understanding of whatever it is that they're going through, because people label it, right? They define it. And if there's a misalignment between the client's perspective and the perspective of the practitioner.
Mm-hmm.
And there isn't an effort to kind of have a really deep understanding.
Mm-hmm.
You can disengage. I mean, one of the things I would think might be a disengagement
Yes.
of the client and poor treatment. Is that
Yes.
is that something that you find?
Definitely, and definitely, and I would add to what you said, which I agree completely with, is that it's not only this understanding of each other, which is the part that the CFI most emphasizes, but it's also understanding the context in which everybody's working, so that the person's place in society, the determinants that have led to the current situation, all that are things, housing, education, jobs, all these are important elements of understanding what is behind the problem and what are the options the person has to solve them. So that in addition to all the interactional elements you're asking. And yes, to answer your question, one of the reasons for doing this work was the disengagement that people had with psychiatric care. I'm a psychiatrist, so I was treating people with medication, and the enormous concerns for depression, the enormous concerns that people had about taking medications for depression, when from the perspective of the psychiatrist, they weren't addictive, they weren't particularly dangerous anymore, even an overdose, many of these medicines anymore. So there were all these technical attitudes that psychiatrists have, that this is no big deal, but that are not shared, by a lot of the population who are very concerned about taking medications, and in some ways rightly so. But you have to engage the person, understand what they're thinking, instead of just telling them, no, just forget what you think, and just. And by the way, that's one pet peeve of mine. We psychiatrists and in the mental health field, we end up distinguishing between what we call the patient's beliefs and what we call our own knowledge or evidence. So it's like we don't have beliefs, psychiatrists. we know. Whereas
you have facts.
We have facts.
The science behind it.
Yes, exactly. Whereas the patient just thinks they know. Whereas in fact
they have bias. In other words, they just basically come.
Yeah, that's another way of saying it. I mean, you wouldn't say, I believe the sun will rise in the morning. It's like it's that level of certainty we think we have. When the level of certainty is misplaced, our field isn't at the place where we know so much. We have all sorts of evidence, and I mean, you should not listen to your doctor because there is such a thing as science and evidence and all that, but it doesn't always trump what the person knows. The person often is more knowledgeable on their experience and life than the doctor.
Well, you say it's very much, when I hear you describe in this way, it sounds very much like taking a shared decision-making kind of approach to it. Is that, it's not just about me having the right answer and then how do I get this person to do it, which can be that kind of an approach, very well-meaning.
Yes, I get it.
Is the idea that I need to have a shared understanding and understand that person's perspective. And around medication is interesting. We were doing some work on wellness self-management, and we were doing a videotape of a particular class, and the class and the wellness self-management curriculum was on medication. And a woman from Puerto Rico actually had said, one of the things about medication, if you're kind of like weird or kind of that's like okay. We just say, Uncle so-and-so or cousin is a little bit off, but you get invited to all the events. And the way in which the person really has a bona fide mental illness is if they take medication. So it was sort of like, wow, not understanding that, where a person's reluctance or concerns or worries about just the treatment around medication, not understanding their perspective on the meaning that it has. Is you can find yourself in this tug of war that's not going to really work. And I think that's an area that like an example of failing to understand the cultural perspective leads us into either disagreements and misalignment, and perhaps people having to lie to you because they don't want to tell you if they don't think that you're going to be understanding and accepting of that. So there's a lot of issues here, and the CFI was a tool that you and others said, look, let's try to contribute to the field, because this is complex, It isn't like, let's just do a webinar and take these things you ought to ask, but rather provide some real resource. Can you tell us a little bit about that tool and how folks might be able to, what's in it really, and if people were interested in learning more, what they might be able to do?
Sure, happy to. The cultural formulation interview is essentially 3 has three components, all of which are protocols of questions. So they're guides for how to conduct an interview. They're not questionnaires in the sense that you fill them out, yes, no, like that.
Okay.
They're open-ended questions in a list, basically, in a structure that guide an interview. So, for example, the main component we call the core CFI has 16 questions. Some have sub-questions, but
Okay.
they're 16 general topics, 16 questions in 4 domains. And they're asked of an individual person, like a provider.
So if you're doing an interview with
Yeah,
me,
yeah.
what would be one of the
Right,
first questions
exactly.
you might,
So
you might ask?
So it's designed actually to start an interview. That's how we like it to be done, because that way we get the person's perspective first, as opposed to starting with our own preoccupations and closed-ended questions about what's going on. And the first question is actually designed to fit the kind of first questions everybody asks, like, what brings you here today? That's essentially the first question, a version of that. But from there, the first 3 questions are the first domain, and they go to try to understand what the person thinks is going on, how they make sense of what's happening, how do they call it even. So one is a general question, what's going on, and then there's a probe that says, there are many ways of answering that question. And we doctors and patients, clients don't need to agree. You could think it's this, you could think it's that. Right. So if we need more information as to what we mean, there's a probe. Then the second question is different, because that first question is like any question any mental health provider would ask. The second question is different than most providers would ask. And that asks, how would you describe this problem of yours, this situation, to somebody in your community, to your family, your friends, or somebody you would tell this?
You know what I love about that?
Mm-hmm.
No, I was a clinician for like 16 years. I never asked that question.
Yeah, it's an
No, what I like about it, it's
question.
an unusual question.
Right.
But now that I think about it, I said, that would be a great question for me to have an insight and understanding of how this person's, how they attach meaning to whatever they're going through.
Yes.
It's how you would explain it to
your
family,
grandmother,
to the grandmother, or something like that.
Right,
So what's going on?
Yeah.
That is like a really great question.
Yeah, thank you. We worked hard on it.
Oh, good.
I see that. Yeah, that was what somebody else suggested. It wasn't my idea, but it was a great idea. Because we are hoping that that what we're doing there is expanding the realm of what is data for the provider and for the person, so that we're saying we're not only just interested in you telling me I've got schizophrenia, because you're repeating, you've been here before, what we want to hear.
Exactly.
We're saying, okay, first we say, there are many ways of answering the first question. Then we say, okay, we realize you may be telling us some things, because it's not like you're lying. That's how you explain it to us, because we may be limited in our understanding of your situation. But how would you explain it to other people, basically? And so sometimes they say, I tell them it's depression too, and okay, so you have a sense. Or they say, no, my grandmother thinks it's X, Y, and Z, and that's how I discuss it with them. The third question is all part of that first domain about what is this? And the third question is, what is it that troubles you the most about it? Because we want to get to the thing that is most bothersome to them, as opposed to I'm treating some label instead of why the person came in.
Right. And
that happens a lot, where the person walks in and I decide they're depressed, and I decide depression is the most important thing that they're suffering from, where in fact they might be there to, for some problem with their family or a job or some problem with the boss or some reason, a lack of money, all sorts of reasons that, sure, it's connected to the depression, but that's not why they're there.
Right.
And out of those first 3 questions, we get a phrase. The provider is asked to come up with
like a summary.
But just a few words. That is what we're going to plug into the rest of the interview, where it says problem, because the next question is, what do you think causes your problem? And there you put in, what is it your causes? You're concerned that everybody thinks you're not telling the truth, about your experience, or what is it that bothers, what causes the fact that you've had this big argument with your family and now you can't get back together. Whatever it is that they said their major problem was.
Right.
That's what we focus the rest of the question. So it's focused on what the person has said is the problem. And of course, as you go along, you may decide you had it wrong, and that as they explain further, they may decide, the person may decide, well, actually, I thought I was here for X, but I'm really here for Y. Right. So you then shift. There's always the possibility for you to refine that phrase. Right. But we want you to use the patient's language.
Well, what's really interesting? I'm trying to think of what's the experience of a client in this process?
Mm-hmm.
And what comes to mind for me is I'd say, gee, this psychiatrist or social worker or psychologist or therapist really seems to care a lot about what's going on with me and how I see things, rather than being this kind of like, I'm a passive contributor, you're asking about I have this symptom, that symptom, that symptom, right? Going off a checklist so I can give you a diagnosis. But rather, it's that engagement in that person in valuing their lives, they're valuing their experience, valuing the meaning, valuing what's most urgent for them in their lives. I mean, that's what's coming across to me.
Yeah, that's what we intend.
That intention. And I think that is an incredibly important message for any practitioner out there. And I know some of the folks who are listening to this, if you do find an opportunity in the work, like your client you're going to see at 2 o'clock or 3 o'clock, and you have not asked some of these questions in this way, and this is just giving you a little sample, because the CFI has other questions, right, to really fill this kind of diagnostic process, but from the client's sort of like perspective, that you can use that would be, I think, a really one possible benefit of being on this, being on this particular conversations with Dr. Tony and listening to the insights really from Dr. Lewis. So that's, I think, an area which I like so much about it, because it's such a strong engagement process. And as you mentioned, it's so important because we can make so many mistakes when we are basically filtering all these things through our own kind of like lens, as opposed to giving that person the opportunity. But it's more than being diagnostic. It's also engaging that person in a way that I respect your experience so much. And I'm going to guide my work and my treatment based upon your experience, rather than shaping you to go along with what I think my treatment should be. So that I think is like really very, very, very important. So we've just about, our conversations with Dr. Tony usually is a 30 minutes to having